Hi, everyone. Let's go over chapter 18 here, thyroid gland dysfunction. You may notice I'll be checking in on my phone and my other computer here just to make sure I am on chat also. So just monitoring everything here, okay? All right, let's go. It's my first time using Zoom in this way, so bear with me here, okay? All right, the thyroid gland is composed of two elongated lobes on either side of the trachea. So they're found right in here, okay? So everybody kind of press right here, and the way you check it is you kind of push it to one side and push it to the other. And then to check this isthmus here, that's, let me get my pen going here. This isthmus right here, kind of makes it an H, is when you swallow, you can feel it kind of just below your Adam's apple, right in this area here, okay? So it's the tissue on either side of the trachea, and then that thin isthmus tissue, thyroid tissue, that's located below the level of the thyroid cartilage. Okay. Now, some people ask, where's the parathyroids? They're kind of on the back, and they're in these little, they're just kind of little nodules here. I'm using a mouse to draw today, so bear with me here. They're kind of located in those areas, and they're on the back. Okay, so we can't really check them. So the thyroid secretes three things, and it's the thyrotoxin, triiodine thyroxine, which is our T3, and our calcitonin. All right. Thyrotoxicosis or hyperthyroidism is the overproduction of thyroid hormones. So they're hormones, so they travel through the blood. And the more common, or the newer word, is thyrotoxicosis, where hyperthyroidism has always been the word of the past. So your boards may or may not have either one of those. I believe your exams will say hyperthyroidism, or your quizzes in this course will say hyperthyroidism. So just know that it is the same thing. It's the overproduction and over too much thyroid hormones in the blood flow. Okay, and then we have hypo meaning below, right? Under or below. And so that's hypothyroidism. So it's the underproduction of the thyroid hormone. I want to just see if I can get, something's bugging me here. I want to watch our chat and I can't see it here. So let me, it is a issue with the PowerPoint, so let me try and sorry about this. And then I'm going to go display settings. We're gonna reverse it, and then I can minimize it. There we go. Okay, sorry about that. Oh, that's not what we wanted. We want this over here. And turn on our chat here. Okay, back to PowerPoint here. All right, so the hypothyroidism is the second most common endocrine disorder, and it's only behind diabetes. Okay, so it's pretty common. We talked about how diabetes is 8% of the population, roughly. I think it's 8.3% of the population. So we're going to be seeing, 4 patients a week probably with diabetes, and I would say hypothyroidism is right behind that. You're definitely going to see multiple people a week on these medications. So thyroid failure usually occurs as a result of disease of the thyroid gland, which is primary hypothyroidism, pituitary gland, which is secondary, and then the hypothalamus, which is tertiary. All right, so predisposing factors of hypothyroidism. It's often an autoimmune disease. And autoimmune hypothyroidism, your boards likes you to kind of know about Hashimoto's thyroiditis, that it is hypothyroidism, okay? Where you can get an acute goiter, and a goiter is found right here, okay? It's where somebody would have just a large lump here, and sometimes it's off to one side, okay? So it can be unilateral. And then the end stages of and then Graves' disease, the end stage would be an autoimmune hypothyroidism. And then we have our iatrogenic, which is caused by the medical profession or caused by medicine. And we have the radioactive iodine therapy for Graves' disease can cause hypothyroidism. Graves' disease is hyperthyroidism, but when we look at the end stages, then they go hypo, okay? And so when we look at thyroidectomy, they're taking the thyroid out for Graves' disease, or for if they have a nodule on their goiter or thyroid cancer, they're going to take it out. And then that's going to cause hypothyroidism, right? And then external neck irradiation for lymphoma or head and neck cancers. Again, going to destroy the functioning of the thyroid. And so you're going to see that thyroid hormone take a dive, okay? Then we have iodine-related hypothyroidism, and it is an iodine deficiency. This is pretty common worldwide, but pretty rare in North America. Iodine excess inhibition of hormones release can unmask the autoimmune thyroid disease, okay? All right, so continuing with hypo, low thyroid levels, predisposing factors. If it's left untreated or uncontrolled, there's an increased risk of hyper-responding to CNS depressants. So what are some of our CNS depressants? Those would include opioids, nitrous oxide, anxiety meds, and that's just to name a few. We'll go into those further in pharmacology, but that's just to name a few. So you start getting a vision on what this looks like, you know, what they're going to respond to or have a hyper response to it. All right, predisposing factors of thyrotoxicosis. Again, thyrotoxicosis is hyperthyroidism, okay? So it begins insidiously, so it seems somewhat harmless, but then it can manifest into Graves' disease, and then can eventually, left untreated, cause a thyroid storm. And the thyroid storm, I do want you to know for your is it quiz or test? I think it's a test. That the thyroid storm is linked to thyrotoxicosis or hyperthyroidism. And I'm just looking to see which test that would be on. I think it's in Unit 7. Okay. Let me try and pull that up here. Okay, let's just keep going here while I try and pull that up, okay? Okay, so what are some of the signs and symptoms related to each of these? So the signs and symptoms are going to help the dental hygienist or the dentist in identifying the following conditions. If undiagnosed or uncontrolled. Now, if they're on medications and it's well managed, we probably aren't going to notice a whole lot, okay? So I want you to definitely know that. Okay, it looks like it's test 4. Okay, so what do we do if we suspect that a patient may have hyperthyroidism or hypothyroidism? Well, we want to get a med consult. Okay, so if they start showing signs, we would want to defer treatment until they're checked out. Okay, yes, it looks like it is chapter or unit 7, test 4. Okay, all right. Okay, so hypothyroidism, if you know anybody who's had it, it has a lot of, I think, fairly clear signs in what, in indicating disease. So you're going to notice hair loss, okay, lethargy, dry skin, so super dry, like scaly dry, okay. You're going to notice achy muscles and weakness, intolerance to cold. That's a really key one. So these are the people that you may see in the summer when everybody else is in shorts and tank tops. These people might be wearing a sweatshirt and jeans, okay? Sounds kind of crazy, but it definitely plays a huge impact on their thermal being, okay? Now, so you're going to see a receding hairline, facial and eyelid edema, so they're going to be swollen right in this region, okay? A dull blank expression, a thick tongue or slow speech. You may notice anorexia, okay, and brittle nails and hair, all right? Menstrual disturbances, late clinical manifestations, you could see bradycardia, so the heart rate is going down. You're going to see a weight gain and thickened skin, and then eventually cardiac complications like cardiac palpitations, okay? Okay. Then on the other end, we have hyperthyroidism. And big key sign, you can see the previous picture versus this one, is that this patient is going to have an intolerance to heat. They are going to be super hot. They're going to have fine, straight hair. They're going to have bulging eyes. And if you look in your book, let me see if I can pull it up on the screen here. Let's see here. Okay, let me drag this over. Okay, hopefully you guys can see this. I'm not sure if you can, but it is on page 288 or 289. I can never tell. I think it's 289 on your ebook. And you'll see that their profile, their eyes are bulging out. Okay, so they're coming out. They're also going to have a flushed face, enlarged thyroid. So unlike hypothyroidism, now we're going to see tachycardia. Okay, so of increased heart rate. Also, you're going to notice an increased systolic blood pressure. And I believe you need to know that. So make a note of that. Okay. You may see breast enlargement. These people are generally really thin. They also have fatigue, but they're kind of always running, almost like a restless leg, okay? And then the finger chubbing and tremors are also noticed with this, and an increase in diarrhea. Okay. Running two screens here. Okay, so let's talk about the physical status classifications, because every time we take a medical history, we evaluate it, we see what the patient checked, yes or no, and then anything that's checked yes, we're going to follow up with. And once we ask all those questions, and this is something generally people know, so they will have it marked under thyroid condition or thyroid disorder, whichever it asks. And so a follow-up question would be, how well controlled is it? Okay, because if it's not well controlled, then we're going to put them in an ASA 3 classification. So if we see any signs or symptoms, say they're having heart palpitations, they've gained a lot of weight recently without knowing why, then we're going to put them into that 3 category. So if we suspect that it's not well controlled, then we want to put them in there. And what does that mean? That means that we need to avoid vasopressors. What is a vasopressor? Okay, so we have epinephrine. All right, that's a vasopressor. So we'd want to avoid epinephrine in these patients. Also, we want to avoid CNS depressants. We just talked about that, right? So this is in hypofunction. Avoid epinephrine in the hyperthyroid patient. Hypo, we're going to avoid CNS depressants such as nitrous oxide, opioids, and anxiety. And I keep saying those 3 because those are 3 that are commonly prescribed in the dental office. Okay? And then we want to have them evaluated for cardiovascular disease also, because there is a strong correlation between the 2. All right. So the pathophysiology, hypothyroidism is a lack of circulating thyroid hormone. So we have the T4, T3, and the calcitron. I probably said that wrong. And hypothyroidism is going to slow the body function, okay? So when you think of that, when we're dividing them, we're going hypothyroidism, think of everything slowing. You're going to see more weight gain with it. You're going to see a slower heart rate, more fatigue. And then we go to our thyrotoxicosis or our hyperthyroidism, and we have excessive thyroid hormones, and that's going to increase the body's energy consumption and elevate the basal metabolic rate. So these people are generally going to be thinner, restless. Okay, so we want to kind of think of, one is speeding up the body and one is slowing down the body. Okay, and a lot of weight loss with hyper, weight gain with hypo. Now, there are either one of these can be life-threatening. Okay, hyper a little more easily life-threatening versus hypo. So hypo, the patient could become or get myxedema, and that's non-pitting edema. And this can cause cardiac enlargement, and that cardiac enlargement can eventually result in death. Okay? And same with hyperthyroidism. A lot of problems with that is include medications, cancers, Graves' disease that can eventually lead to loss of life. So need to be really aware of those. But what I really want you to focus on are these. Okay, so we want to avoid vasopressors. I'm trying to put ink on this, but it's not working. I'm not sure why. Okay, so avoid vasopressors. with hyperthyroidism and avoid CNS depressants with hypothyroidism. Okay, I'll just use my laser pointer. Maybe that'll work. Who knows? Nope. Okay. All right. So the management of the patient with hypothyroidism, if it's well controlled, no management is necessary. However, if it isn't controlled and the patient is now suffering from myxedema, this could lead to a coma. All right. So this is the wrong information here. So myxedema, you would want to, this says thyroid storm, and that is not correct. Let me see if I can cross that out. Nothing wants to work for me here. All right, so nope, it's not going to let me. Okay, well, this is thyroid storm. Yes, you pretty much the management is the same. You're going to recognize the problem. You're going to discontinue treatment, position the patient in supine position with their feet elevated. And then CAB, of course, you're always going to be assessing the circulation, airway, and breathing. Okay. Sorry. And then definitive care, you're going to activate emergency medical services immediately for both of these conditions. Okay. Establish an IV if possible, if your doctor is licensed to do so. But one thing we can always do is administer oxygen. Okay. The only condition, or I want you guys to think about this, what is the only condition that we've studied so far that you should not administer oxygen to? Okay, I want you to think about that. All right, and look it up if you don't know the answer. All right, and then you're going to either discharge the patient if it resolves or send them to the hospital via an ambulance. Okay? All right, so again, they're pretty much the same. So here's the same information. All right. One thing I do want you to know is, remember, is that hyperthyroidism is has a very slow onset, but then can become problematic very quickly. So it kind of goes hidden for a long time, and then all of a sudden it manifests in a big way. Okay? Let me just review this. Yep, just the gradual onset is the biggest thing you need to know about. Okay, with the hyperthyroidism. Also, which one are we going to see an elevated blood pressure with? If you don't know, please rewind this, go back to it so you can review that. Okay. All right, let's move on to our cerebrovascular accident. Cerebrovascular accident, or CVA, is how we refer to it. And that, I want you to know, I'm going to attempt my pen again, even though it's really not working for me. Oh, it might this time. No. Oh, it's doing that. But it is the third leading cause of death in the United States, behind heart disease and cancer. Okay, so you're going to have patients that have had strokes. So how do we manage them safely, right? How do we provide safe, effective care to these patients? This is the leading cause of disability with adults. All right, so very interesting, I think, that statistic. CVA is the most common form of brain disease. After a stroke, a patient can all of a sudden start having seizures, or, there is damage to the brain, okay? Women account for 61% of stroke deaths in the United States. So women have a higher incidence of stroke. The mean age of a stroke was almost 80 years old, okay? Now, there are risk factors that can make a person more likely to have a heart attack early on, much before that age. All right. So we basically have two classifications, but I threw in the TIA in there. The two classifications are the occlusive and the hemorrhagic. All right. But I wanted to make sure that you guys know what a TIA is, and that's a transient cerebral ischemia, and it's an incipient stroke, okay, or just a mini stroke is what a lot of people refer to them as. And it's these constant brief episodes of cerebral ischemia where the brain just isn't getting enough blood, okay? So it's kind of under that occlusive classification, but it's not occlusive, okay? So for one reason or another, they're just constantly not getting enough blood to the brain. And remember, the blood provides the oxygen and glucose to the brain, right? That the brain so desperately needs. So these episodes of TIAs, and I want you to know this, can last anywhere from like 2 to 10 minutes, okay? So if it's something lasting that brief of a period, then, and the patient's fine, then we send them out for a med consult. And we're going to go through this at the end. But if these keep happening or it gets more severe, then of course they're managed very differently. All right, occlusive, at least 80% narrowing of the blood flow. So that number is important. Please highlight that and circle it. The narrowing of the blood flow needs to be between 80 and 90%. 80 is on the low end, okay, before this is going to happen. Now, Lesueur infraction is the most common lesion, all right? But cerebral infarction is the most common occlusive stroke, and really the most common stroke. I believe it's like 85 or 87% of strokes, okay? Then we have our hemorrhagic, which is our bleeding strokes, all right? Or our blood strokes. So we're going to have the intracerebral hemorrhage and the subarachnoid. It's like I need to not look at it when I say it, right? All right, so risk factors. What I want you guys to take away from this, first and foremost, is that consistently elevated blood pressure is a major risk factor in developing both occlusive and hemorrhagic stroke. So if you're asked in a case study or in a direct question on your boards, what is the major risk factor, or which of these is most likely the risk factor for a patient, you're always going to select elevated blood pressure for strokes when a stroke is suspected, okay? Always select that. Now, are there other risk factors? Absolutely. Diabetes, we talked about that in chapter 16 and 17, or more in chapter 17. Diabetes, very common comorbidity between diabetes and cerebrovascular accidents. Disorders of heart rhythm, family history and genetics is a huge indicator also. Smoking and physical inactivity. All right, so know all of the risk factors, but be sure that if you are ever asked which one is the most common or the best choice, you always want to select elevated blood pressure, All right, prevention. Prevention of the occurrence or reoccurrence of CVA is based on the recognition of risk factors. So when you get a patient's medical history, medical, dental, and social history, let me go back to the previous slide here. On the medical history, you see diabetes, or you see dysrhythmia, an irregular heartbeat, or that in the social history, you see that they're a smoker. Or maybe you see a physical inactivity, okay? Some medical histories ask if you exercise and how frequently. A lot of them in dentistry don't, but also remember that physical inactivity is tied to type 2 diabetes. And that's why we're seeing that diagnosis earlier and earlier in life. All right. So when we look at our medical history and we see those things, we need to be aware that we need to eliminate as much stress as possible. All right, so our stress reduction protocol should come in. So first of all, physical exam. Are they thin or are they heavier set? Okay, maybe the heavier set, now doesn't mean every heavy set person doesn't exercise, right? I know some very thick people that exercise all the time, all right? Just tons of muscle. But you're looking at that, okay? It's a factor. And then you notice that the blood pressure is elevated, all right? And that the patient is a little apprehensive with the dental visit. All right, now we need to start thinking, what can I do to reduce this patient's stress? All right, such as having appointments early in the morning, right? Playing calming music, good pain management, all right? All of those things are going to start coming into play to prevent an event in the office, an emergency in the office. All right, so what does it look like when a patient has a stroke? They often will report a headache. Again, a lot of times people will say it's like an ice pick, okay? Mental changes. Are they confused or disoriented? What other condition did we see that with? The confusion and disorientation. I want you guys to think about that because we have studied that in the past, okay? So if you don't know, come and ask me, or what I prefer is that you guys always look these up. That helps you remember it better, okay? But often you're going to see it with stroke, but again, you can see it with another condition that we talked about, and I want you guys to bring that to class, okay? Aphasia, which is a CVA in the left hemisphere. So this can be unilateral, right? So you might see one side that has paralysis after an event, okay? Respiratory problems, okay? Remember, the brain is helping everything function, right? It's telling us to breathe, even. It's telling our heart to beat. So we need to be aware of what effects a stroke has on us or on our patients, all right? So you may see a patient that all of a sudden they check seizures on their medical history, all right? They never had seizures before, but they don't check that they had a stroke. So again, a follow-up question would be, do they know what caused your seizure? All right. Transient hemiparesis, all right. Temporary vision changes, and lasts a few minutes to 24 hours. So it can last up to 24 hours. Visual changes, vomiting, perceptual defects. So just read through this. Again, focal neurological signs and symptoms, you're going to see paralysis, sensory loss, language disorder, and reflex changes. There we go. All right, so dental therapy considerations. We want to consider the time that has elapsed since their last CVA. So do you guys remember how long it takes before we can safely see them for elective dental treatment? I want you guys to think about that for a second, okay? And that is 6 months for elective treatment. Now, if the patient is in pain and more urgent care is needed, they would need to be seen in a hospital. Minimize stress. Again, what is some of our stress reduction protocol? I want you to think about how we're going to prevent this patient from having another stroke in our office, because once they've had a stroke, then there's a high chance that there's going to be another one, okay? Assessment of the post-CVA patient. Is the patient too great a risk for treatment? You know, how were they affected physically by this event? Did they end up with paralysis on one side? Can they speak, right? So we need to look at what ASA classification they are. So one big difference between TIAs and CVAs is that a TIA has no residual side effects, okay, or long-term effects, I should say. Whereas CVA, you're going to see more of the physical or emotional effects of that event, okay? And then assessment of bleeding. One thing I want you to know is that these patients, especially if it's due to a clot, these patients are going to be on blood thinners. So we're going to look at anything from is everything safe? Are we up to code on the American Disability Act so that they don't fall and bleed, right? You're going to notice, because of their blood thinners, you're going to notice a lot of bruising sometimes on their arms, where maybe loved ones have rubbed them and they just bruised that easily just from a pat. So, when you start seeing people with these signs, start thinking, okay, they might be on a blood thinner, or they have something going on with their blood. Generally, it's going to be a blood thinner. And then, think about how that's going to manifest in the mouth, right? They're going to bleed a lot easier in the oral cavity too. All right. All right, so clinical manifestations of CVAs, I want you to know that it really is dependent on what type of CVA they had. So an infarction has a gradual onset of signs and symptoms. So just like our hyperthyroidism, right? We see a gradual onset. Okay, it can be minutes to hours to days. TIA frequently is preceding it, so if they have a history of TIAs, we need to know that there's a chance for an infarction. Headache, usually mild. Neurologic signs and symptoms you may see, and then again, some blindness that comes with the TIAs. Excuse excuse me. Embolism is an abrupt onset of signs and symptoms, so it takes seconds. So differentiating the infarction from the embolism, all right? Infarction is a gradual onset. Embolism and hemorrhage strokes are both abrupt signs and symptoms, okay? It literally takes seconds for this to happen to somebody. They're going to notice a mild headache, unlike the hemorrhagic, which is a violent headache. And then you're going to see some of the neurological signs and symptoms over the next few hours. So maybe they start to see their lip and their eye droop, okay? They would want to call emergency services because there's a lot of really great things that emergency services can do to prevent a full attack, but also to help preserve the brain and prevent any long-term effects. So Minnesota's kind of a leader in that area. We're really lucky. All right, now a hemorrhagic stroke, this is a brain bleed, okay? Embolism is a clot. Hemorrhage is a brain bleed, all right? Then they're going to get that sudden violent headache, and it's going to make them nauseous. They're going to have chills, and they're going to sweat, okay? Dizziness or vertigo, neurological signs and symptoms, again, looking at the droopiness, loss of consciousness. So this can be a cerebrovascular accident, or it could be, depending on how drastic it is, a TIA. All right, so pathophysiology, cerebrovascular ischemia and infarction. As the ischemia develops, the ischemic tissue becomes soft, okay? So that tissue around the blood vessels. And normally, the well-demarcated border between the white and gray matters in the brain becomes less distinct. And this causes a shortage of oxygen and glucose needed for cell metabolism in the brain, okay? Then we have a hemorrhagic CVA, and they differ clinically from the non-hemorrhagic CVAs in that their onset is generally more rapid and the symptoms are more intense. Like, it's more obvious that something's happening, okay? It's the most common source of, is blood. And sometimes, you wonder, how do they know if somebody had a stroke, a hemorrhagic stroke? And it could be, if it was kind of minor and it passed quickly, they will see dried blood on the brain, okay? When they do a MRI or a CT scan of the brain, they'll actually see a spot where there's dried blood on the brain. All right, two primary causes that exist for this form of CVA is the subarachnoid hemorrhage resulting from a ruptured aneurysm and the intracranial hemorrhage resulting from hypertensive vascular disease. Hypertensive, think high blood pressure, right? High blood pressure is our most common sign and symptom, or risk factor for strokes. All right, so the management. The stroke chain of survival is extremely important. We're going to recognize it quickly and react to the stroke warning signs. You're going to call EMS, dispatch them immediately, and everything's just going to happen very quickly, okay? Your book has, let me see if I can pull up the book here. It open somewhere here. There we go. And it has an interesting little chart, box 19-2. So the emergency department arrival to the doctor, 10 minutes. Between the arrival to the CT scan completion, 25 minutes. So you can see, how long things take in an emergency department. If you look at box 19-3, you're going to see how very quickly they move this along to prevent any further damage to the brain. And it really increases the patient's survival also. All right, so you want to position the patient as long as they're conscious. If they're unconscious, we're immediately calling 911, right? We're leaving them calling 911, not leaving the patient, but they should be in a supine position. So we're going to position them comfortably as long as they're awake, all right? We're going to check the circulation, airway, and breathing, and administer basic life support as needed. And then our definitive care is that we're going to activate the EMS, all right? Even if they say it's a TIA, we're going to activate the EMS. We're going to monitor the vital signs every 5 minutes. That's kind of the standard. You don't want to do it more, quicker together, only have a short duration. And that is because the blood pressure is going to increase because they haven't had time to recover from that cuff. So we want to see it every 5 minutes, and you should be recording this, remember. We want to record it so that we can hand it off to the personnel when they get there. Management of signs and symptoms and follow-up management. Generally, we aren't going to have a lot of follow-up, but you want to make sure that the patient follows up with their physician and is on the proper medications to prevent this in the future. All right. So here's our CVA and TIA management. One, you're going to position the patient comfortably, assess breathing, circulation, airway, and breathing, and provide basic life support as needed. And then our definitive management is going to depend on what we're doing, right? So we're going to, for all of them, activate the EMS. For all of them, we're going to monitor the vitals every 5 minutes. Manage the signs and symptoms. If blood pressure is elevated, place the patient in the semi-Fowler position. Okay, so that is, let's see here, I believe that's on your book, in your book here. It's a semi-seated position, okay? Let me see if I can find what page it's on. I believe they have a picture. Sorry. Semi-Fowler. Fowler. All right, I'll get that to you soon. I'm not sure. Maybe it's not in your book. I think it's in your book, but it's not labeled. I know it's in there. It's right under all of this. Sorry, I'm looking for the page. All right, there it is. Let's see here. That is figure 19-5. It is labeled the semi-Fowler. Didn't come up on my search. But it's where the patient is semi-upright. All right. So then we're going to administer oxygen. All right. So we do not want to administer any CNS depressants. Now, if the symptoms resolve, we're going to tell the patient they need to follow up with their physician. Okay. If symptoms persist, we're going to send them to the hospital. Okay. And actually we're not doing this, the EMS is going to do this, but know that this is what's going to be done. Now, if they lose consciousness, we're going to start thinking it's a hemorrhagic CVA. We're going to position the patient. Now they're unconscious. We're going to put them in supine position. We're going to elevate their feet. Okay. Then we're going to assess for basic life support, right? We're going to monitor the vitals. And if the blood pressure is elevated, we're going to reposition the patient into the semi-Fowler's position. So blood pressure elevated, raise the patient up. All right. Definitive care, establish an IV access if the doctor's licensed or you're licensed to do so. A lot of oral surgeon's office, if you end up working there, or even a perio office, will have the ability to start an IV. And if available, they're going to transport to the emergency care facility. So if they establish an IV, hopefully the paramedics can take it with. All right. Any questions, please email me or go ahead and put it on the chat. Again, I am watching the chat and I'm not seeing any activity as of right now. So hopefully that's a good sign, right? All right. So let's move on to our differential diagnosis. And this is going to be nice and quick here, okay? I think. All right. So first and foremost, make sure you get a good medical history or history interview, okay? And I don't want to even say medical because medical limits it. We want a good medical and social, right? Because of some of the risk factors. But a good medical history is going to indicate if conditions have already been found. And then we can do our follow-up questions, right? And then our follow-up questions are going to help us determine the degree of risk that the patient is at. That's our ASA classifications, right? I have a question for you. What ASA classification would it be is the patient that has had a stroke in the last 6 months? What ASA classification are they? I want you to look that up, okay? And what each stage is. So 2 is usually they've had it, but they're controlled. 3, they're going to have permanent damage, or blood pressure might be slightly elevated still. And then I'll just tell you 4 is going to be where we aren't going to administer care for any elective services, right? And that, so they would fall into the ASA category 4 for that first 6 months. Just like with a heart attack, they're going to fall in the ASA category 4 for the first 6 months, okay? All right, so summary of the differential diagnosis. Hyperventilation, you're going to have a respiratory rate that's rapid, and the individual demonstrates deep respiratory excursions. This generally isn't going to happen in young, healthy children, okay? So I want you to see the age range here, 15 to 40 years of age, all right? I want you to be aware of that, because if somebody young passes out or somebody over the age of 40, then we need to start looking somewhere else, right? All right. At some other condition. So some patients may experience paresthesia of the end extremities, all right? So like your fingers and your toes, and some circumoral tingling or numbness, all right? So hyperventilation, you're looking for reports of tingling or paresthesia on fingertips, toes, perioral, and then you're going to think of it first for those in the age range of 15 to 40, okay? Then hypoglycemia, most are going to have it marked on their medical history, and then you want to make sure you follow up. Are you type 1 or are you type 2? Okay. So when we're looking at hypoglycemia, remember the patient that doesn't have diabetes can still show signs of hypoglycemia, okay? So they just haven't had anything to eat. Again, we're going to treat it with orange juice or some sugary drink in the office. So this patient, they may appear drunk and their skin is cold and wet to the touch. So cold and wet to the touch. Their heart rate is going to be rapid, and the patient may exhibit tremors. Now, this onset of symptoms may appear quickly or lead quickly to the loss of consciousness. All right. I need to move my picture. Okay, hyperglycemia. I guess I know what it says. These individuals often have histories of inadequately controlled diabetes. In the hyperglycemia, the skin appears hot and dry. Okay, so when we look at the skin of the hypoglycemic versus the hyperglycemic, one is cool and wet, that's hypo, and the other hot and dry. And then this one, I want you guys to know that we're going to notice that sweet odor of acetone on the breath of this patient. Their breathing is going to be rapid and deep, which is known as the Kussmaul's respirations. And then such patients experience more gradual onsets and symptoms, and they rarely lose consciousness. So if you have to choose between one or the other on a test, you're going to know, or on your boards, you're going to know that the one that's going to lose consciousness is going to be hypo. Okay? You're going to see cold, wet skin versus our dry, hot skin on our hyperglycemic. Okay, this isn't moving for me. There we go. All right, now let's go into hypothyroidism. So we went over hypoglycemia, low blood sugar, and we went over hyperglycemia, overproduction or too much blood sugar, right? Now we're going to go to too little thyroid hormones in the blood. And these patients, remember, see how we have hypo and we're seeing cold here also? Body temperatures are lowered, no sweating in these patients. Okay? Speech and mental capabilities may appear slower than normal. Peripheral edema, that's the non-pitting edema that can become myxedema, and that is the life-threatening condition that you're going to see with hypothyroidism. Keynote here, they're going to be overly sensitive to, when it's not controlled, they're going to be overly sensitive to CNS depressant drugs. Okay? Hyperthyroidism, what do you think their body temperature is going to be? Hyper, high body temperature. Okay? High heart rate, high blood pressure. All right? The skin is going to be wet and warm. So that's a little bit different than our hyperglycemia. That was hot and dry. Now we have wet and warm. Okay, to the touch. And they overlie, and they're overly sensitive to heat. Most patients report recent unexplained weight loss accompanied by an increase in appetite. They're losing weight, or they're losing weight, but they aren't eating much. All right. Now our CVA are for those individuals suffering the hemorrhagic CVAs, usually report intense headaches all of a sudden. They experience unilateral, so one-sided neurologic deficits. Okay, so one side, either the right side or the left side. The level of consciousness is normally unchanged, though unconsciousness may occur with the hemorrhagic. Okay, so if you all of a sudden, again, one of the tests are to say, you know, can you tell me the sky is blue? And they say Cleveland is hot, then you know that something's happening, okay? Because in their mind, they're saying what you just said. They didn't hear it wrong. but their brain is not signaling to them what they need to say. It's telling them they're saying one thing, but they're actually saying another. It's kind of a crazy phenomenon. All right. Please review that. I will send out a worksheet or have one with me on Monday. Okay. Have a great weekend, you guys. Take care.